More seats available here in this side and function room 2. Can we request our colleagues to probably transfer to occupy the vacant seats? Thank you. There are more seats here at function room 2. We will be using both functions room 2 and 3. Okay, good afternoon. Welcome to Convention Symposium 5 on TB updates. I am Dr. Maria Lourdes Villa, the co-chair for this convention symposium. This will be chaired by Dr. Regina Berba. So there will be three topics for this symposium. The first is on diagnostic algorithm for the diagnosis of tuberculosis. The objectives of this lecture will include discussing the most recent diagnostic algorithm for the diagnosis of tuberculosis, to enumerate common concerns and provide answers in terms of referrals for TB diagnostics. The second lecture will be on MDR-TB regimens, the management and approach of available drugs for the treatment of MDR-TB will be discussed, as well as common adverse reactions, monitoring and management of MDR treatment regimens. And the last lecture will be on clinical utility of quantiferon and the principle behind the quantiferon assay and some studies validating its clinical utility will be discussed, as well as recommendations on the use of quantiferon assay and how to properly interpret results in different clinical scenarios, and issues and challenges in terms of its use, implementation, and interpretation. So our three speakers include Dr. Ana Marin Celina Garfin, who will discuss on diagnostic algorithm for the diagnosis of tuberculosis. She is a medical specialist from the Department of Health, Disease Prevention and Control Bureau, a former medical specialist 3, Department of Health, TB Control Service. The second lecture on MDR-TB regimens will be delivered by Dr. Maria Tarcela Gler, who is the Training Officer, Section of Infectious Diseases at Makati Medical Center, Head AMS Clinician, Antimicrobial Stewardship, Makati Medical Center, as well as a member of the Technical Review Board for FDA, National Institute of Health, Philippines. And our last lecture on the utility of quantiferon will be delivered by Dr. Masei Kawamura, and she was introduced to us earlier, and she is TB clinician for more than 30 years and served as San Francisco's TB controller from 1996 to the end of 2011. As a U.S. TB controller, she was a national leader in policy, TB education, and actively promoted technology innovation to improve patient care and program performance. Her program led to the nation in being the first to adopt the interferon gamma release assay blood testing for TB screening in 2003 and the gene expert testing for active TB diagnosis in 2010. So we will now start the session. Dr. Garfin.
So good afternoon, everyone. I'll be sharing with you our diagnostic algorithm. This is what we're using for the National Tuberculosis Control Program. So first, let me share with you that we have a high TB burden in the country, and globally, that is for 2018, there are about 10 million new TB cases, and 8 countries account for 2/3 of all TB cases. And Philippines is contributing 6% of those cases. If we compare our country with other ASEAN countries, we have the highest incidence rate. So we have 554 per 100,000 population, and that is about 591,000 TB cases. And if you notice, the next country from us is only 338, so very high TB incidence rate. So for 2018, this is our accomplishment. There is about 26,600 TB cases that died. But I would like to share with you that for 2018, we were able to report 371,688 TB cases. So that is a high jump from the 317,000 in 2017. And 10% of those cases are coming from the mandatory notification. So that is from the private physicians. So maybe some of you have contributed to that accomplishment. Thank you. But with this accomplishment, we are still missing about 220,000 TB cases. So we need to find them if we really have to end TB by 2035. And during the UN high-level meeting last year, our country committed to find 2.5 million TB cases. So we need to find them if we have to decrease our incidence rate. And it means all of us should contribute to this accomplishment. So our commitment is to do, that is number 2, reaching the targets through active case finding. So we'll do massive X-ray screening and expert testing. So how are we going to find these cases? So for now, we have 2 key strategies. We will do systematic screening. So we do this in all health facilities wherein we do symptom screening. So the symptoms would be 2 weeks of the following, cough, fever, loss of weight, and night sweats. And in the health facilities, this shall be the primary screening tool. And when we say systematic screening, meaning all those that are coming to the health centers or to the health facilities, we will be asking them if they have these symptoms. So if they are presumptive TB, then we will do expert testing. And this means we'll be using expert as our primary diagnostic tool. Another strategy is we will do active case finding, wherein we will go to congregate settings, targeted community, and workplace. We will do chest X-ray as a screening tool, and then expert will also be the primary diagnostic tool. So if you noticed, or if you are aware of the diagnostic algorithm before of the TB program, we don't really consider chest X-ray. Before, we just say you should undergo direct sputum smear microscopy. But now we're looking at chest X-ray as a screening tool and not just the signs and symptoms. Because based on the 2017 or 2016 National TB Prevalence Survey, among all those detected TB cases, only 1/3 are symptomatics. But 98% of them have chest X-ray findings. So if we have to be sensitive, then we will have to use chest X-ray as our screening tool. So this is our diagnostic algorithm. So we screen all for the following signs and symptoms. So 2 weeks or more of cough, unexplained fever, unexplained weight loss, and night sweats. So if you have this, then you will be considered as a presumptive TB. Then we will request for expert testing if this is available in the facilities. Not all now have the gene expert, but we now have 488 expert machines distributed nationwide. But we also have our striders, so they transport the specimen. So if you don't have expert in the facility, the specimens now will be transported to the expert center. So if you don't have the signs and symptoms, then we have to look at the risk factors. So these are the risk factors. So contacts of PTB, retreatment, if you are a PLHIV, elderly, diabetic, smokers, healthcare workers, urban and rural poor, and if you have immunosuppression. So those are the risk factors. If you have that, then we will request for chest x-ray. Then if the chest x-ray is suggestive of TB, then you will be considered a presumptive TB and we will request for expert testing. So for the systematic screening for people living with HIV, we will be screening using chest x-ray and symptoms. And this will be done at the time of diagnosis. Then we will also do symptom screening at every visit. So we need to check if they have the signs and symptoms, and chest x-ray will be done annually. So in the previous slide, if you don't have PLHIV or if you are not a PLHIV, the signs and symptoms should be 2 weeks or more. But for PLHIV, it is of any duration, but same signs and symptoms: cough, fever, loss of weight, and night sweats. Then if you have this and a chest x-ray, then you will be considered a presumptive TB. So this is the algorithm. So at the time of diagnosis, and if you have HIV, so we'll screen for the signs and symptoms plus the x-ray. If it's a yes for one of the signs and symptoms and suggestive x-ray is suggestive of TB, then we will collect one sputum sample and then request for expert. For every visit, it's still screening for the symptoms, and then if it is positive, then we will request for expert. So in all health facilities, it is free. Expert is free. And we should also note that expert detects the DNA. So even if it is a dead bacilli, it will still detect the TB bacilli. That's why we are using expert only for diagnosis and not for monitoring of treatment. For children, we will be identifying them as presumptive TB if they have one of the 3 signs and symptoms, and that is coughing or wheezing of 2 weeks or more, unexplained fever of 2 weeks, and unexplained weight loss. So if the child is a contact of known TB case, we will identify them as presumptive TB if with fatigue, decreased playfulness and activity, and anorexia for 2 weeks. And if they have a chest x-ray findings of suggestive of TB, then we will also identify them as presumptive TB. So once they are considered as a presumptive TB, then we will request for expert. Okay, so now we will go to the active case finding in targeted community, workplace, or congregate settings. So these are the priority target population groups. So we have the community, so these are the urban and rural poor, workplace, and these are mostly informal workers, because we know in the formal sectors, they have the screening when they start their work, and they also have their annual examination. Then for congregate settings, this will be at the jails, detention center, residential homes, or residential care facilities. So we will do mass screening, and this would be chest x-ray for all. So for children, we will only do symptom screening. So the algorithm for this is we screen all for chest x-ray, and then if they are suggestive of TB, then we will identify them as presumptive TB and we will request for expert. Then another high-risk group would be the healthcare workers. So we will also do screening for them. And when we say healthcare workers here, it would consider also the janitorial services, the ancillary staff, and then the maintenance and even the ambulance drivers, since they are exposed to the patient. So this would be the diagnostic algorithm. So we'll do baseline screening when the staff is recruited. So we'll do this through symptoms and then chest x-ray. Then we'll have follow-up screening biannually through symptoms, and then follow-up screening annually using symptoms and chest x-ray. So if they are presumptive TB, then we will also do chest expert testing for them. Another group would be the contacts. So we'll do chest x-ray screening for 5 years old and above among the drug-susceptible TB. Then if chest x-ray is not available, then we'll do symptom screening. But for contacts of the drug-resistant TB cases, all of them have to be screened using chest x-ray. And if we don't have chest x-ray, then we'll do expert. So that's for the drug-susceptible TB, it's expert, but if it's not available, we have an option to do first the direct sputum smear microscopy. But for the contacts of the drug-resistant TB, it's expert right away. Then we'll also provide preventive treatment for the contacts of the drug-susceptible TB. But for the drug-resistant TB, it's not recommended that we provide preventive therapy for them. But we will do follow-up for both contacts of drug-susceptible TB and drug-resistant TB, and this will be done every 6 months for 2 years. So in terms of diagnosing them, we will diagnose them either as bacteriologically confirmed TB or EPTB, and this will be based on the result of the expert, the microscopy, and if TB lump is available. So why is it important that we have to classify them as bacteriologically confirmed or clinically diagnosed? It's because we now have a more sensitive tool, and we want to ensure that we are not over-diagnosing our cases. And it is to determine really the burden of TB in our country. Okay, so how do we do the diagnosis? So for patients below 15 years old with negative expert, or the DSM results, or the DSM is not done, but still with persistent signs and symptoms, we can request for chest x-ray if it was not done initially, and if the result is suggestive of TB, then we classify them as clinically diagnosed. Meaning after doing all the tests and we are still convinced that they have TB, then we can still classify them as having TB, but we will label them as clinically diagnosed TB. Okay, so this is our diagnostic algorithm for children below 15 years of age. So it's presumptive TB. So we have the signs and symptoms, and then with or without the risk factors. Either they are contacts of our TB case. So if they are presumptive extrapulmonary TB, then we'll do expert testing also. So expert can also be done for extrapulmonary specimens. So this can be the pus, tissue, or fluid samples. Then if they are presumptive TB, then they have, and if they can expectorate, then we will also do expert testing. So if it is positive for TB or for rifampicin resistant, then we will start the treatment. If it is negative, then we'll request for chest x-ray. Then if it is suggestive of TB, then we will start the treatment, or these are the clinically diagnosed TB cases. So the diagnosis of TB is if they are extrapulmonary TB, and can be confirmed bacteriologically using expert testing. Extrapulmonary TB can be assessed as clinically diagnosed TB based on the signs and symptoms and other examinations. Okay. So if the expert result is MTB only, that is without rifampicin resistant, then we will consider them as drug susceptible TB and we will start first line anti-TB drugs. For high risk MDR groups, or that is for high MDR TB risk with expert result, that is they have high risk for developing MDR TB, then we will consider them as drug resistant TB. However, there are also patients that have low risk for MDR TB, and once we detect them for rifampicin resistant, we don't label them right away as rifampicin resistant. We have to repeat the testing for expert. Based on the data that we have, about 10% of these cases are not really rifampicin resistant. That is why we are repeating the expert testing. Then one of the result of expert would also state if it is indeterminate, invalid, or error results. So we have to repeat the expert testing. So this is the summary of the diagnosis and clinical application of the expert. So if expert MTB test is done, the result is MTB. MTB, that is the first, MTB or no rifampicin resistant, then we treat with drug susceptible TB regimen. But if it is MTB positive with rifampicin resistant, high risk for MDR TB, then we start the treatment for drug resistant TB. But if it is low risk for MDR TB, then we recollect the specimen for another testing, just like with the invalid result. But if there is no MTB detected, then we'll do clinical follow-up, and if still suspicious of TB, if no chest x-ray before, then we still do the chest x-ray. Then we can give antibiotics, do other investigation, and if we are still convinced that the patient is TB, then we can refer it to our TB Medical Advisory Committee. Then if there's really no TB, then we'll just do clinical follow-up and investigate for other lung diseases. So for the TB program, we're moving towards using chest x-ray as the screening tool, expert as the primary diagnostic tool, and we provide the treatment based on the result. So this is all for the TB program. Thank you.
Good afternoon. So I was tasked to talk about the treatment for MDR-TB. What is the verdict now? I have no disclosures. This would be the outline of my talk. So Dr. Celine has already talked about the burden of TB. And in fact, in 2014, TB surpassed HIV as the #1 infectious disease killer worldwide. And for MDR-TB, in 2015, 600,000 cases of rifampicin-resistant TB was reported, but less than 25% are recognized, which is why diagnostics is very important. In the Philippines, the burden of MDR-TB as of the last year's DRS survey for new cases, we have 1.7%. As compared to the global data of 3.4%. And for previously treated, we have 16% rate of MDR-TB compared to the 18% globally. So I'll just go back to the history of TB treatment. So after sun and good nutrition, there was rifampicin in 1943, and then there was several drugs discovered years after that, and then it stopped with rifampicin in 1965. So the amikacin there and moxifloxacin were really not developed for TB. They were developed for other infections, and they were just discovered to have TB activity. So, and just the history, the clinical trials that was done to come up with our standard regimen. The standard regimen that we have now, the HRZ, which we call, or RIPE for other people, has gone through almost 40 years of clinical trials, starting with the first clinical trial for TB, the streptomycin, by the BMRC, and the addition of rifampicin to the resistance phenomenon was realized with the single drug, and then addition of the several drugs, until rifampicin was added to the regimen, which shortened the 18 months treatment to 9 months, and then PZA was added. So they looked at relapse in these trials. They looked at relapse rates. As you see here, when rifampicin was added, relapse rate went down from 29% to 2%. With PZA and rifampicin added, relapse rate went down to almost, so this one, and the addition of rifampicin to the regimen, the relapse rate went down to 3%, and when there's PZA, relapse rate, without rifampicin, relapse rate was at 8%. So our drug now, our combination, our standard therapy now is the perfect combination with 2 months of INH, rifampicin, PZA, and ethambutol, and 4 months of your INH and PCH. Cheap, highly effective, at 95% effectivity, relapse rate of less than 5% when fully administered, and went through several trials. So this is the hypothesis as to why this combination works well, because it is active to the different populations in that an active TB has. INH works well with an actively dividing population, as well as your streptomycin, some streptomycin. PZA works well with intracellular organisms, and rifampicin works well with your semi-dormant organisms, and your ethambutol is just mainly to protect INH resistance. So the principles of TB treatment then is to use a combination of chemotherapy with at least 2 or more drugs, in which patients organism is likely to be sensitive from the outset. You should never add a single drug to a failing regimen, and bacteriostatic drugs like ethambutol can be used to prevent emergence of drug resistance. And the duration of treatment must be long enough to kill slowly dividing and persistent organisms. And DOT has been part of the standard care for TB. So I will just, before I go to the MDR-TB, I'll just go through the optimization of our HRZ. Are we giving the right dose? Data has shown that drug levels for our first-line drugs, this is data for rifampicin, shows that for a cohort of slow responders, more than 50% of the drug levels, despite DOT, has been low, and especially among diabetics and amongst HIV-infected patients. So 86% with rifampicin or INH levels were below the lower limit of the reference range. So what is the right dose? Several trials have shown that 35 milligrams up to 35 milligrams has been effective and was well tolerated. So the verdict is not yet out as to what is the right dose for rifampicin, but WHO is working on changing the recommendation. Definitely it's not 10 milligrams per kilo because of the low PK of these drugs. So just had to mention this, and higher rifampicin appeared to be well tolerated and more effective. So now going to MDR-TB. So in any relationship, we have the perfect combination. There's always a twist. And with TB, there's the emergence of MDR-TB, or an isolate which is resistant to INH and rifampicin, and your XDR, which has an isolate which has further resistance to injectable agents, and fluoroquinolones, which are the two important, which have been the two most important drugs for MDR-TB. So just going through the evolution of the WHO guidelines. Before 2008, this was the guideline for treatment of MDR-TB. We had to use the old drugs before the HRZE, and you had to choose from each class to complete at least 4 to 6 effective drugs, meaning the patient has not been exposed to that drug and the isolate has to be sensitive to that drug. So we were giving 4 to 6 types of drugs to patients, and there were no fixed dose combination for these drugs, so patients would have at least 12 tablets and 1 injectable agents for 6 months. And this is just the cascade of choosing the treatment for XDR-TB, which I will not go because this is passé already. We don't do that anymore. And then in 2011, it was changed. The recommendation of the WHO was changed to have the most important point here was that PCA had to be added, injectable agents had to be extended from 6 months to 8 months, and as you see here, all of the data these are strong recommendation but very low quality of evidence. Most of the evidences for this treatment regimen were based on cohort studies. There were no trials done for treatment of MDR-TB at that time. And then in 2016, this was updated because there was a big cohort of the 9-month regimen in Bangladesh, where the WHO has recommended that most patients should be given the 9-month regimen. I will tell you the 9-month regimen in the next slide. So this would be the regimen for the 9-month regimen. It's 4 months of 7 types of drugs, including a high-dose INH, prothionamide, kanamycin, moxifloxacin, ethambutol, PZA, and clofazimine, and 5 months of continuation phase, removing your kanamycin, high-dose INH, and prothionamide. So, so as you see, there's our most likely, all of the drugs are first-line drugs except for, and probably patients have been exposed to, except for clofazimine, kanamycin, and amoxifloxacin. But several cohorts has shown that the outcome, the cure rate has been up to 86%, which is much higher than the conventional regimen that we were giving to patients. And then there was the approval of the new and repurposed drugs. The linezolid was recommended based on a data in Korea of extremely drug resistant, extensively drug resistant, or XDR-TB, basically patients who have no treatment alternatives. When they were given linezolid, so basically they were exposed to linezolid only, there was still an 87% sputum negativity within 6 months of treatment. And delamanid was approved in 2016 based on a phase 2 study where the patients given delamanid versus just the conventional regimen for MDR-TB had a 50% higher sputum conversion rate at month 2. So, and the phase 3 trial, which was reported in 2013 and published this year, though showed that there was no difference between the conventional regimen or the optimized background regimen only versus the patients who were given optimized background regimen plus delamanid. As you see here, the cure rate for the study arm is 81%, and the control is 81.2% also. So there was our analysis here was there was a big jump in the treatment standards within the 5 years that the first trial, the phase 2 trial, was done to the phase 3 trial. So if done well and if managed well, patients, MDR-TB patients can actually have very good cure rates at 81% versus the comparative, our historical cure rate was at maximum of 60%. So, and bedaquiline is another drug that was actually the first one which was approved in 2013. It's a it's a diaryl quinoline, which is has an activity against ATP synthase, and it was approved with the phase 2 trial showing a cure rate of 57% amongst those given additional BDQ versus a 31% cure rate amongst those without BDQs. As you see here, this was completed in 2012. So you see the cure rates of conventionally treated patients was 31%, big difference to the newer trials. But the concern here was 30 death. There was a higher death rate amongst patients with BDQ, but this was not shown in subsequent cohort studies using bedaquiline, which I will show later. And this is the newest drug that was approved just this year, bretomanid. It's another nitroimidazole group, molecule which inhibits mycolic acid synthesis like the delamanid, and it was approved this year with a condition that it can only be used with linezolid and bedaquiline, because the trial that was used to get its approval is a regimen trial. So the first clinical trial for a regimen for TB was for the 9-month regimen. It was called the Stream 1 trial. So the two trials that was advertised here is the trial 213 for Delamanid and the Stream 1 trial. So the Stream 1 trial is a placebo-controlled trial for, not placebo-controlled, it's a randomized controlled trial, open label, a non-inferiority trial for this, the 9-month regimen versus the conventional WHO regimen. And the non-inferiority margin was 10%, but the non-inferiority margin was actually beyond, it went beyond, the results went beyond the non-inferiority margin, which was explained by the trialist or the proponents of the trial as because they did not expect, again, for the control to do well. So the cure rate here for the control was 81, almost 81%, versus the cure rate for the study arm at 78%. And the criteria for unfavorable outcome for this study is very stringent. Just changing 2 drugs in the regimen was already unfavorable, or having adverse event was an unfavorable outcome. So, but you could say that it's near it's near non-inferiority. So the WHO has changed the recommendation from almost everybody being given the 9-month regimen. This was released in 2018 as an interim recommendation to certain populations, limited. There has to be a criteria for choosing the 9-month regimen, and longer regimen was now the recommendation in 2019. They changed the groupings again of the second line drugs. So as you see, there was almost every year. Now they're reviewing another guideline change for 2020. So there's talks now for a guideline change by 2020 publication. So now for group A drugs, the drugs here would be levofloxacin, moxi, levofloxacin and moxi, bedaquiline and linezolid. And group B are clofazimine. So clofazimine was demoted to group B. Cycloserine was up to group B. And the C's are the support drugs, where ethambutol, delamanid, PZA, and the other drugs are included. So the recommendation are again conditional recommendation with very low certainty in estimates because there has been no trials. So the recommendation was to use all of A and then add a C, add a B, I mean, or add 2 Bs. So I will show you later. So the Philippines, this is our recommendation now based on that recommendation. So we still recommend for those who are eligible for 9-month regimen, we still recommend the 9-month regimen, and the all-oral regimen for those with fluoroquinolone resistance. So the 2019 recommendation of the WHO is for more towards an all-oral regimen. As you see, kanamycin and cycloserine and capreomycin was removed from the list of the drugs. So 18 to 20 months of the combinations of the 3. If there's resistance to fluoroquinolone, you add delamanid to the regimen, and an individualized regimen would be following the WHO of completing based on the classifications. So the South Africa uses this standard regimen. It's the revised 9-month regimen without the injectable agent. So but there are several ongoing trials, which I will just go through fast in the interest of time, of looking at the 9-month regimen or even shortening the 9-month regimen to the 9-month regimen for MDR and XDR TB, having a pan regimen for all types of TB. So trials that are replacing injectable is the next MDR end, the Stream 2 trial and the END trial. So the next trial is just a 6 to 9 month bedaquiline-based regimen. With this regimen, it's ongoing now, and the expected results should be by next year. And the MDR end trial is comparing the standard regimen of 20 to 24 months with the lamanid-based regimen. This is in Korea. It should, I think they've completed enrollment and will be releasing results by 2021. And this is the Stream 2 trial. So they looked initially at the 9-month regimen versus the A and B. Now the Stream 2 is looking at a regimen without injectable agent, replacing the lamanid and by the bedaquiline I mean, and the regimen D would be a 6-month regimen with injectable agent. So that's the Stream 2 trial and their ongoing enrollment now. And the NTB trial. The NTB trial is an observational study. They've enrolled actually 2,700 patients already, and they're looking at these combinations of regimen, and their interim results they've released last year in July 2018 showed that they just showed a safety analysis that there were no, the concern for the two new drugs, the lamanid and bedaquiline, was the QTC prolongation, and their data showed that there was minimal QTC prolongation, but there was a high, amongst patients given injectable agents, there was a high adverse event or injectable agent related toxicity, and 11% of those given with linezolid had at least one toxicity. And for the delamanid analysis, 79% had culture conversion within 6 months, and 63 lower amongst those with HIV. With those with injectable agents, those who had susceptible strains to injectable agents, it's actually higher odds of conversion compared to those not receiving injectable agents. So I think there's still a benefit of the injectable agents in the treatment of tuberculosis if you have no more choice. So I'm not very agreeing towards removing the injectable agents because we need these choices. So the other trials are the treatment shortening trials. So the next TB is actually the trial that was used to for the approval of pretomanid. It's a bedaquiline pretomanid linezolid regimen where they've shown an 89% conversion amongst patients. They've enrolled only XDR TB patients, an 89% conversion. And this was approved based on a 45 patient result. So, and the TB Practical is another trial. Simplicity is a trial that is also ongoing, and one of the sites is in the Philippines, which is a bedaquiline pretomanid based regimen. So in the Cure 3B, this is still a trial to be proposed, which looks at not treating TB as a one-size-fits-all. It looks at risk stratification. So if you have a cavity and you have a smear plus 3, you will have a longer regimen. If you have a simple smear negative or +1, then you can have a shorter regimen at 4 months. So this will be started only. It's being proposed but not funded yet. So this is how our TB drug pipeline looks, and it's very active, and it looks very hopeful for me as a TB clinician. So in summary, TB has been an ancient disease, yet it still kills a lot of Filipinos. The present doses of the standard TB regimen has still to be optimized. There are many more options now for MDR and XDR TB, but RCTs are still needed to get the best combination and the appropriate duration. Thank you.
Good afternoon, everyone. Thank you for staying for this last talk of our session. And I want to compliment the previous speakers. I'm really impressed by the work of the National TB Program and also the MDR work. And the lower MDR rate of 1.7% compared to the global rate shows that the TB program and the treatment of active disease is very strong in the Philippines. So congratulations on that. And also in participating in the MDR TB trials. So I'm going to be talking about QuantiFERON TB Gold Plus, which is the current version. And I'm going to just start off with comparison to the skin test. As you know, there are all those problems with the skin test, but the biggest one is the patients coming back. In the best kind of scenarios, even under research, if you have a 10% drop off in the return rate or a 90% return rate, it's considered really good. But that means you have a 10% drop in sensitivity. And if they're high-risk contacts, you have to chase after them and start the whole process all over again. And that's why our program went to an IGRA, which was the first QuantiFERON as soon as it came out, because we had a problem with return rates, especially with our HIV population. Our return rates was less than 50%. So, you know, besides all the special training that's needed, the subjectivity for the skin test, it's also a manual test. So there's data, problems because you have incomplete data, you have errors in entry of the data, and that's a problem for TB control programs. You actually erase all of those with a laboratory-based test. I mentioned earlier today that with QuantiFERON Plus, with the CD8 response that you can calculate, you actually have a broader picture of the immune system, which is quite relevant in contacts and those who are suspected of active TB. In the United States, where I come from, actually, we're talking about ending the use of the skin test. And this was a paper that came out by a very prominent key opinion leader on pediatrics. And she's one of our national speakers, Andrea Cruz, talking about the case for retiring the skin test. And they're basically saying, why are we using this old test that's not specific when you have a much more accurate laboratory-based test, right? So why are we still reading bumps on the arm? And that's our perspective and the perspective of many TB control programs. So just to go over the pathway, just wanted to show you that, I mentioned that the first QuantiFERON turned the skin test into a blood test. The second QuantiFERON made it much more specific because instead of using PPD, it changed it to liquid antigens. The third QuantiFERON which was quantiferon gold in tube, was really a benchmark for laboratories because they put the antigens in the tubes, which allowed remote incubation. And after incubation, you actually have 3 days to run the assay, and that's why it has been scaled up worldwide in commercial labs in every region of the world. And now there's over 60 million of these tests that have been sold, and an explosion of research, over 1,600 articles on quantiferon gold in tube. And so we come to the quantiferon fourth generation, quantiferon plus, as we call it. It's a new benchmark again because of the CD8 antigens. But before we get to quantiferon plus, I want to show you the vast amount of data, and I've just only included the articles that I feel are actually well done in high impact journals. In every risk group that you want to target for tuberculosis, quantiferon is actually performing better than the skin test. So in terms of sensitivity, correlation to risk, etc. And so, it's generally accepted now that it is a better assay. And also showing higher rates of progression compared to the skin test when they're positive. And so most of you probably don't know because you don't use quantiferon. Can I ask the audience, how many of you have actually used quantiferon or an interferon gamma release assay, which it is? Can you raise your hands, please? Okay, not too many. Raise them high. I can't see. Okay, so just a small handful of you. But how many of you are using the skin test? Raise your hand high. Oh, not that. Okay, a little bit more. I think you're a little shy. But used to be like that in the United States where everybody raised their hand for the skin test and there was only a few people raising their hand for quantiferon, but now it's just the opposite. Quantiferon is an FDA-approved interferon gamma release assay. It's recommended by the WHO. Quantiferon is replacing the skin test in the best TB programs in the United States, in all the big city programs, and the best programs in Asia. And I hope that the Philippine National TB Program will also adopt quantiferon for some of their targeted testing. Like I mentioned before, interferon gamma release assays, quantiferon is superior to the skin test in BCG vaccinated populations. The specificity is only 51%, so it's really hard to tell whether your positive skin test is due to BCG or to a true TB infection. Quantiferon performs consistently in high-risk groups, as I mentioned. It correlates better to risk. It is the global research tool for all for biologics, for vaccine research, for national TB surveillances. And there's a large study that will be starting in India, testing 40,000 patients. Quantiferon has been shown to be cost-effective, but not at the prices that you have in the Philippines. And so I hope that all of you will advocate, if you want to use this test, band together with your public health program and demand more reasonable pricing. And operationally, we know that getting a blood test is much more convenient for patients because they get a result with one patient visit, and it really does result in higher quality care. It's also convenient for the doctor because they have an electronic result that they can rely on. So quantiferon plus is actually an improved version of the previous one. I mentioned the sensitivity and specificity, sensitivity of 94% in active culture-proven TB, specificity of greater than 97%. It has the CD8 antigens, and it's also now, it's WHO endorsed, as well as on the GDF list for public health pricing. So there are also these the flexible blood draw options. You can draw it into a single lithium heparin tube, I also believe it's approved for sodium heparin tube use because it's more common to have sodium heparin tubes. So you can draw it the usual way and send it to the laboratory. And but you got to make sure your laboratory is willing to transfer the blood into the 4 quantiferon tubes, because the 4th generation has 4 tubes. And so why did we choose CD8 antigens? First, you need to know about CD4. Now, everybody knows that CD4 they are key to the immune system, and that's why HIV has been such a problem, because the virus actually infects CD4 cells. It doesn't infect CD8 cells, though. The CD4 T cells are like the general of the cell-mediated response. It recruits and tells the other inflammatory cells what to do. The CD8 T cell, however, it transforms into a killer cell, like a CIA or MS6 kind of cell. And when it detects a cell that has TB in it, and it's also true for cancers and viruses, etc., the CD8 will go and kill that cell, whether it's a brain cell or it doesn't really matter. The CD8 T cells can kill any cell. It can program that cell to die. It can help the cell lyse the internal bacilli, etc. And so, in other words, it is a biomarker. The response is a biomarker for intracellular TB burden. And so where do you see the CD8 response? Basically, you'll see it more frequently in active TB compared to latent TB, because of course the burden is higher. You're going to see it in contacts or those who are newly infected. You have good responses in HIV because HIV does not impact a CD8. And also in young children. And it's also, the CD8 response decreases with TB treatment. And these studies that I'm quoting you are all studies using flow cytometry prior to the development of quantiferon plus. And this is why these antigens were selected. So the difference between the 3rd generation and the 4th generation are the 2 colored tubes. Quantiferon has controls. Unlike the skin test, there is a negative control. Let's see if I can get this to work. There's a negative control, the gray top, a positive control, the mitogen, and that's the same is true for quantiferon plus. The old test, quantiferon gold in tube, had TB antigens that mainly focused on stimulating CD4 T cells. These were the longer peptides, ESAT6, CFP10, and TB7.7. With quantiferon plus, there are 2 tubes, TB1 and TB2. TB1 has antigens, longer peptides that stimulate CD4 T cells, ESAT6 and CFP10. TB7.7 was removed because it didn't add any sensitivity to the assay, and it just added costs. So it was removed. So the TB2 tube has both CD4 and CD8 stimulating antigens, both long peptides that stimulate the CD4 and short peptides that are proprietary that impact or work with the CD8 T cells. So that's the big difference. So people ask, okay, why do you have 4 tubes? And the reason for having 4 tubes and not having only the TB2 tube is because when you have 2 antigen tubes, you have double the results. You have actually more information. Stochastically, it can increase sensitivity. You can also use it for technical information. Now, these 2 tubes in LTBI should be duplicates, be very close in the quantitative value to each other, or the TB2 tube should be definitely higher if you're having a CD8 response. It also allows you to calculate the CD8 response by subtracting the CD4 interferon gamma by subtracting TB1 from TB2, okay? And so why do we care about that? Remember, we talked about this morning the spectrum of tuberculosis. And, just have the skin test and the older quantiferons once you're infected, they're positive, and you really can't tell where they are on the spectrum, right? But with a CD8 response, okay, you should see, when you're newly infected, you should see a burst of CD8 activity. Once that infection gets controlled by the cell-mediated response, it should go away. And then as you move towards active tuberculosis, you will see a CD8 response again. And that response should get stronger. And so this is in our package insert for QuantiFERON Plus. So what do you see in terms of that CD8 response? The surrogate is by subtracting TB1 from TB2, the quantitative values. And what you see in the low risk is that you really don't see CD8 activity, whereas in the mixed risk, where it includes contacts and homeless individuals, et cetera, there are a few people that have CD8 responses. And so one has to wonder now these individuals with higher risk, are these individuals recently infected, and are they more likely to progress? And when you look at active TB, you can see that the majority of these individuals, not all, but the majority, have a CD8 response. So you can imagine, and the response is much stronger, okay? But you can imagine when you're on the fence, you have an 18-year-old with maybe a kind of a subtle upper lobe infiltrate, maybe a slight cough, not very sick, but you have a very strong a QuantiFERON response and a strong CD8 signal. That may drive you to collect sputum or even start treatment, right? So this may be helpful. It's not a claim, just to be frank and upfront with you, but it may be useful. So just a warning, however, we think this is the greatest thing on earth, but it's still an immunoassay. And you saw that there were many active TB patients in the previous slide that didn't have a CD8 signal. And so the lack of a CD8 signal cannot rule out active TB, okay? Or subclinical tuberculosis that will progress. We don't know that yet, right? And definitely we know that there will be, not all active TB has CD8. However, if you have a CD8 signal and it's a strong signal, then that may be able to help you with your TB, your patient management, in putting them into the spectrum, into the correct place of the spectrum. So let's look at the performance. Just briefly, I have a few studies here. The first meta-analysis just came out and was published, I believe, 2 or 3 months ago. And the objective was to look at the accuracy of QuantiFERON Plus compared to QuantiFERON Gold INTUBE. And they searched the literature using the typical kind of search and analyzing it for scientific quality and bias. And they found 15 articles. So now there are actually 45 published articles on QuantiFERON Plus because it's been out since 2015 in Europe. And so most of the studies were observational and cross-sectional, but the pooled sensitivity in active culture-proven TB was 94%, which is exactly the same as our package insert. So that is really good news in terms of the sensitivity. The pool specificity in a healthy person was 96%, very close to the 97% of the package insert. And then for the pool sensitivity and specificity for latent TB infection was lower, which is interesting, but it's because it's compared to another assay, QuantiFERON INTUBE. So basically their conclusion was that QuantiFERON Plus was more sensitive than QuantiFERON Gold INTUBE for active TB, and that was mainly due to TB2. So again, this is showing you the CD8, the value of the CD8 antigens in that tube. So what about contacts? And now contacts are really important. We're always looking for new infection. And why are we looking for new infection? We're looking for new infection because, we say the lifetime risk for developing TB if you're infected is 10 to 15% or 5 to 15%. But half of that risk is within the first 1 to 2 years after you're infected. So identifying that newly infected person is really important. You can decrease the number needed to treat to like 20 people, right? If you're saying it's 5%. And it may be higher with IGRAs. The WHO actually got so excited about the first study in contacts with quantiferin plus, they even made mention in their 2016 report about the first study showing that the first results indicate that the CD8 T cell response may be able to identify people at greater risk of progression to active TB. So they were talking about recent infection. And here is the study that was published by the Italians, Barcellini. Very quickly, they started off with 119 skin test positive individuals at 5 millimeters. You can see they were tested with quantiferin and quantiferin plus, and with quantiferin plus, half of them or less than half of them were positive, and so you can assume a lot of false positives in this cohort. With quantiferin plus, there was an additional 12 that was found that were quantiferin gold negative. And also, what they found when they calculated and looked at the CD8 signal, they found that 15% of this whole cohort had the CD8 signal, but if you only looked at the positives, 25% of the quantiferin positives had a significant CD8 signal that was over 0.6 international units per ml. And this signal was statistically significant and associated with proximity to the index case, sleeping in the same room, and also associated with being European as opposed to foreign-born, where you would expect more, old TB infection as opposed to new TB infection. And overall, the positive results of quantiferin plus more strongly was associated to risk than quantiferin gold intube. So they concluded that quantiferin plus had better improved performance compared to quantiferin gold intube in contact investigation, and that the CD8 response could perhaps be used as a proxy for recent infection. So since that time, there have been several other studies looking at contacts and the CD8 signal. And you can see under Barcellini, which was the study I just showed you, there's a Peterman study from Scandinavia, multiple countries in Scandinavia, that included 127 contacts. The Lee study was from Taiwan, 223 contacts, and Gurjov, 189 contacts from Mongolia. So, we're building an evidence base here. You can see the positive rates in that middle column in yellow being very high, 50% or around 42 to 57%, around 50%. But you can also see that all of these contacts had CD8 signals, indicating a significant proportion may have had recent infection. I'm saying may because we can't be sure for certain until we actually look at progression studies. Also, in the Gurjov Mongolian study, they found that the positive response from quantiferin plus, as well as the CD8 response, was associated with the intensity of exposure, sleeping in the same room again, same kind of results, as well as low vitamin D levels and malnutrition. So it's really panning out, and there are many other studies looking at active TB versus latent TB. It's showing higher, stronger CD8 signals in smear positive versus smear negative. There's some studies now on treatment showing a decrease in the CD8 signal at the end of treatment, but these studies are very small. So it's really, this CD8 response is correlating to TB burden thus far in these studies. And what about immunocompromised populations? This is really what quantiferin plus was developed for. The healthy populations, quantiferin gold was performing really well. But in immunocompromised populations like HIV, in patients who are on immunosuppressive drugs, et cetera, this is where our third generation test and also the T-spot did not perform as well, okay? So these are studies, just some few studies. This is the first study from Africa in the Zambia looking at HIV and its impact on quantiferon. In the blue circles here, you can see that there were 108 patients who were diagnosed with TB either by PCR or smear. You can see that there were HIV positives and negatives, and the sensitivity of quantiferon plus was 85% in HIV positives and 80% in HIV negatives. It actually looks better, but this is not statistically different because of the small numbers. Also, when you look at CD4 counts, you did not see a decline in the sensitivity until you get under 100 CD4 cells. With the old quantiferon, this was a study that was done in the same institution, same study design, actually compared it to the skin test. Quantiferon actually performed better than the skin test, but you can see the impact of HIV on the quantiferon. The sensitivity was only 63% compared to 84%. And also the impact by CD4, anything below 350, you see a huge drop off in the sensitivity below, and horrible sensitivity below a CD4 count of 100. Okay, so this has been, so far there is no impact by HIV status and less impact by CD4. There's another study, LTBI study in pregnant women from Ethiopia showing the positive rate of LTBI being 33% without any change by status HIV. So far it looks really good. Now, this is another study, but this is an LTBI study from Taiwan in elderly in long-term care facilities. This is a problem worldwide, especially in high-burden countries, outbreaks in the elderly. And so they're testing their elderly and preventing and providing prevention there, as we do in the United States. And basically what they found, they actually did sensitivity and specificity. They did that by repeating the test, and if you repeated positive, then it validated the first, so that was a true positive, and if it was negative, you were a reverter, then that wasn't significant. And what they found comparing quantiferon gold intube to quantiferon plus was that there was a higher positive rate. You can see 32% versus 28.8%. The sensitivity they calculated was 100% with a specificity that was almost identical and a negative predictive value of 100%. So, quantiferon plus performed better in the elderly with a higher negative predictive value. And this was clearly related to age, because over the age of 75, you could see a big drop off in the quantiferon gold intube sensitivity. And again, the TB2 tube, the CD8 antigens seem to make a big difference here. So this is another study from Japan. I'm showing you this because it not only is about elderly, but it compares it to quantiferon gold intube and T-spot. Quantiferon plus had the highest sensitivity in this 80-year-old, average age of 80 years old. This is not a very large study, but it's a significant study, and Dr. Fukushima has added more patients, and the results are the same. He's now at up to 130 patients. They use a T-spot cutoff of 8 spots, using a blood age of over 8 hours with the T-cell extent. And you can see a huge difference with both quantiferons and T-spot. Both quantiferons did extremely well and was statistically higher than T-spot. These are all pulmonary culture-proven cases. I also want to point out the indeterminate rate being much lower for quantiferon plus compared to T-spot, and better than quantiferon gold intube. But the next part is more interesting to me. So when you look at the results by age, those under the age of 80, both quantiferons performed equally and still a lot better than T-spot, but T-spot performed better also here. Once you get to over 80, this is where you see a big difference between the assays. Quantiferon Plus is pulling ahead in sensitivity of both assays. And then when you look at those with CD4 counts less than 200, you see a drop in sensitivity, yes, but not as much as quantiferon gold intube and T-spot. So 83% is still quite good for active TB. And so here you can see the performance in comparison with both assays. And in rheumatoid arthritis, this is another Japanese study, another small study, but still I think significant, 154 patients, more on the older side, 66 years old. And they also looked at CD4 and CD8, which I'm not going to talk about here, but these patients were actually quite sick. 63% were on steroids, 53% were on biologic agents, and 76% were on methotrexate. Now remember, we're supposed to test them before we put them on the immunosuppressives. So these are really sick people. You would expect false negatives in this cohort. But what you see when quantiferon plus is compared to quantiferon to T-spot is that the positive rate is double that. So it's 9.7% positive versus 4.5% for T-spot. The indeterminate rate was also lower. You had an indeterminate rate of less than 1% compared to 2.6% for T-spot. So in this comparison study, quantiferon plus had a higher positive rate than T-spot, but neither met the background rate of LTBI for that age group. So caution is needed. Still, these tests are not are perfect, and they rely on the immune system. So even though quantiferon plus is better because of its CD8, et cetera, it's still not perfect, but it's still better than what we have. So, as far as the evidence, the two new meta-analysis show better performance of quantiferon plus compared to its predecessor. The CD8 studies are really panning out, showing correlation to new infection, exposure, and active TB burden. Compared to quantiferon gold intube, quantiferon plus has higher sensitivity in the elderly in both active TB as well as latent TB. And unlike quantiferon gold intube, quantiferon plus is less impacted by HIV and low CD4 counts. And then finally, the comparison studies show that quantiferon plus is significantly more sensitive or more positive than T-spot in LTBI. So I just wanted to have you all think about this. Now, if you don't have an accurate test, for example, you're just treating without testing, or you're testing with, say, the skin test and you have 59% specificity, these are just my own rough kind of calculations. If you have a short course regimen of 3 HP, and this is wrong, I think it's $15, not $16, and you're testing 10 million people, it will cost you $160 million in treatment. But if you were to half that cost because you have a more accurate test, then it'll cost you $80 million. Also, the labor, if you're saying it costs $10,000 per staff, and you have 300 patients per staff, which seems kind of like a lot, but maybe not. This is the rough kind of estimate that I've heard and that we've used in our own program. It would cost you quite a lot to monitor that treatment and to administer that treatment. You calculate the X-rays as well as a 1.5% side effect rate, which is at $10 per event, and you end up with a grand total of $508 million. Okay, but if you were able to reduce the positive rate by 50%, okay, and you could do this by 60%, you have a $254 million waste. That's a lot of waste. So I just want to point that out. And while quantiferon and the IGRAs are much more expensive, if you had an IGRA that costs $25, you would have the same exact cost, but you wouldn't have the waste or the toxicity and treatment of those patients. So it would be affordable if you didn't have the waste. That's all I'm pointing out here. And of course, costs vary across the world, but I calculated this for a hybrid setting. So what's the clinical utility of QuantiFERON Plus? The accuracy will reduce the number needed to treat and the waste associated with false skin test positives or not testing at all. The results are really provider and program friendly. The results are also patient-centered because they can get an electronic result printout. As I mentioned, the CD8 response can provide a broader picture of the immune response and perhaps place your patient in the spectrum more accurately. The new GDF, or Global Drug Facility list price and donor funds, can make QuantiFERON affordable for public health. And the evidence and current performance of QuantiFERON Plus and QuantiFERON and the QuantiFERON technology from the past shows that it performs very well in high-risk populations and better than the skin test. So I want to end here and thank you for your attention.
Can we give a big hand again to our three speakers? And I'd like to ask the audience, are there any questions that we'd like to direct to any one of our speakers? Yes, Dr. Lagamayo.
Thank you very much for the very detailed and informative lecture. I would like to ask Dr. for the regarding the QuantiFERON reporting. Yes, right now we are doing the QFT, St. Luke's Medical Center Global City, and we are using the TB Gold Plus. But we are just reporting positive or negative results or indeterminate results. So with your lecture, after listening to your lecture, would it be possible to help the clinicians better if we will report the value of the TB1, TB2 in terms of international unit per ml?
As well as the NIL and the mitogen. Yes, our package insert recommends the reporting of all the values.
Okay.
And I think in particular, the way I teach on how to look at these results, you want to look at your controls first to make sure you've got a good test.
Yeah.
You don't have a high background nil, which can actually interfere and cause false positive results because of variability in the tubes. Also, you want to look at a healthy mitogen response.
Yes.
In an immunocompromised patient, you may have a low mitogen response and a negative, but you can look at the antigen tubes, and if you have a response that's close to the cut point, even though it's not positive, you as a clinician might say, oh, I'm going to say this patient is infected because she's a contact. So, depending on the context, that or a weak response, I believe the quantitative values are really important. You can also detect technical issues, from looking at the quantitative values. So thank you for that question.
Yeah, thank you very much.
May I invite our speakers to come up here for any more questions? Nahuli, no? Okay. So, okay, are there any more questions? This is your chance. I mean, we don't usually have this extra time. We actually have 29 more minutes. Yes, Dr. Janice.
Thank you for our three speakers. For the talk, I have a question for Masai. There are results coming to us with indeterminate results. So how do we explain that? That's number one. And number two, what are your recommendations for retesting? Like we know that this is a contact. The initial test was negative. And do you have like recommendations or guidelines or any studies that, that shows or supports a second test?
Thank you for that question. The first one was about indeterminates. And, doctors hate that result because it's like a non-result, right? But the indeterminate result is actually very valuable because many technical issues, if you have a healthy person who should have a healthy response, and they didn't have a vaccine, and they weren't sick in the last few weeks, and they have a mitogen indeterminate, you probably have a technical problem. And they shouldn't be indeterminate. And so in that patient, when you have an indeterminate, the recommendation in the package insert, which I fully agree with, is to repeat the test. Now, if your patient has an indeterminate result because they were sick or they're hospitalized and they have a biological reason to have their immune system suppressed, then I would wait until they're healthy again. Or they may be on steroids, okay, like really high dose steroids or something. Then you would, and that's a different story if they're on chronic steroids. When do you repeat again? Nobody knows, But in general, you want to wait until that person is healthy again. Maybe it's a month or 2 months. Hopefully the test is not critical, right? This is not a test that you would use to make your diagnosis make or break for active TB, right? So that indeterminate result can be valuable, though. Like I mentioned earlier, in active TB, you can still look at the 2 antigen tubes. If you have an immune response, even though it doesn't cross the cut point of 0.35, that may be significant in a TB suspect because active TB is immunosuppressive. And that's why you see false negatives in the skin test as well as any IGRA test. Okay, now your second question was about retesting. So in contacts, you would use the skin test exactly like you would the skin test. You would repeat just as you would repeat with the skin test. In a contact, you would do your testing right after the exposure, right when you discover the contact. And then if they're negative, you would repeat it 8 weeks later. Okay. The weakness, however, with all the IGRAs is that we have a very weak definition of what a converter is. Okay, conversion meaning new infection. The conversion definition, according to the CDC, is going from a negative to a positive. That's a qualitative negative to a positive. So you can be 0.34 on your first test, and your second test you're 0.36. But in essence, those results are exactly the same, and you're called a converter. But is it new infection? Probably not. You probably just had the same response. And so there's now talk about an uncertainty zone. And this is a study that came from South Africa. I can give you that reference by Neems. That's her last name, I believe. And they found that if you're less than 0.2 international units and you go above 0.7, those converters had a much higher risk of progression in 2 years compared to those who converted within that uncertainty zone between 0.2 and 0.7. So if you went from 0.2 to 0.4, those individuals didn't progress to active TB in 2 years, or it was the same as the negative people, So I think that if you're doing serial testing, you should always look at the quantitative values to see if you have someone who is wobbling around the cut point or really jumped when they went to positive. So that's my only advice. Of course, you can do that in healthcare workers, and that's how I know that it's been a problematic area. because we don't have a strong definition of conversion. And the CDC has acknowledged this in their 2010 guidelines, that it's a weak definition and it will lead to more false conversions, as opposed to just wobblers. I hope that makes sense. Thank you.
Hello, good afternoon. I'd like to shift the spotlight to Maricel on the treatment for drug-resistant TB. Are there now reports of resistance to bedaquiline and the other drugs used for? And then are there standard tests to determine if there is resistance? And if there are no tests, how do we as clinicians, when do we start thinking about failure on those agents?
So there are now reports of bedaquiline resistance. One other report was actually released in the New England Journal, a case who migrated an African, I don't know where, a Mongolian guy going to Switzerland, and he had resistance to bedaquiline over the course of the treatment. And with Delamanid, in our study, there were actually some patients who had, 2 patients who had baseline resistance to Delamanid, but the test, the DST, the phenotypic DST for both drugs is still being, it has not been released to the labs, it's still being finalized, but there's a genotypic test for, because the gene responsible for this resistance has been identified. There's genotypic testing, but it's also not finalized yet. So one of the requirements for programs, of course, is to have these tests, to have DST for all of the drugs when you're using them, because it's necessary for you to know amplification of resistance, but at this time, that's one of the limitations. There's no test for all of the drugs yet.
Can I ask a question?
Oh, yes, Dr.
So thank you for your good lecture. I have a question about, we know linezolid for MDR is a great drug, except that it causes a lot of neurotoxicity. It's very frequent. Do you know anything about sutazolid, which is like the cousin, and it's supposed to be less toxic? What do you know about it? Is anyone using it, and is it less toxic that way?
So actually last week we had a memorial lecture for Dr. Thelma Topasi, one of our the MDR-TB mentors in the country, and the guy who lectured, Dr. Charles Wells, is actually involved, is now the leader of the Gates MRI. They're using they will be using, because the trend now is not to do single drug discovery for TB. Right. It should be a regimen discovery. So this is what the Gates MRI will be doing. It will be like a regimen discovery, and they have sutazolid in their pipeline.
Great. Thank you.
And it's a good drug.
Okay.
I
We
a
have a
quest-
lot of time.
Okay. I have a question for Celine. Celine, you mentioned the algorithm for diagnosis of pulmonary tuberculosis. How about for extrapulmonary TB? Do we also recommend doing the expert now for extrapulmonary specimens? I mean, doing expert for extrapulmonary specimens, and can we access also free gene expert for our specimens from these patients?
We are doing, we are accepting specimens, extrapulmonary specimens using expert, but these are in selected, sites only, like in NTRL, POC, they are accepting specimens, not all, because they need to have a centrifuge to do that.
So also because of access, because we want really to, to help DOH attain the goal of detecting all those patients by 2022. How can we encourage the private to, to use the gene expert to increase the number of cases to be treated?
So they need to coordinate with the local government units, because right now what we're doing is to improve access of the private physicians for the expert. The striders, or that is the transporter of the specimens, are also going to the private physicians. So we need to coordinate with them so that they can zone that hospital or that clinic for the pickup of specimens.
And also we've heard that, there will be this consortium. And I think that this should be also the case for quantiferon. But maybe Celine can now discuss about the consortium of laboratories that is being organized to decrease significantly the cost of expert in the private setting. Because, it's really difficult sometimes to go to the public facilities, number one. The public centers are closed during weekends and holidays, but hospitals are open 24/7. So we do operations, so we do testing 24/7, and we would actually want to utilize gene expert, and I think that the hospitals can still do it, the private clinics can still do it, the private labs can still do gene expert, but we would want to have the cheaper gene expert.
So for the consortium, this is a technical assistance from a USAID project wherein they discuss with the different hospitals for them to group together and agree, wherein they will procure expert cartridges and machines. So this will be in bulk so that they'll have a cheaper cost. Then they agree on what would be the cost of that expert cartridge or the test. But they have just started. I mean, they said they will procure the first batch of cartridges as well as the machines. So the cost is lesser if it's within the one private hospital alone. But they said the price is not that cheap as of the latest.
So it's
Kasama kayo ba?
actually,
Oh, yes,
right.
Chinese Gen is part of that consortium. What's the cost?
Well, according to them, it will be it will be cost at 2,300 flat rate. That would be inclusive of the senior citizen. So there is no more senior citizen discount or PDW discount. So it's a flat rate, whether inpatient, outpatient, ICU patient. But it is it is estimated to arrive. The machine will be arriving by January, and this is the first batch. And we hope that some other private hospitals will join soon.
Yeah.
It's cheaper than what is the price, the current price of the expert, no? Of the expert test.
The price of
It's
the
cheaper.
expert of the machine, if you will buy the four modules, it costs more or less 1.3 million only. Compared with the price with the commercial company, it's 4 million. And the cost of the cartridge is only $22 if you join the consortium. And if you buy it commercially, it would cost at, I think, 5,000 pesos. That's why it is priced at about 7,000 per test in a private hospital.
Yeah.
So it's a big...
yeah. Just that some other people who might not be familiar with the term consortium, it's actually led by the Philippine Coalition Against Tuberculosis. It's we're trying to get all the private facilities to join the consortium and push the pricing of the gene expert down. And if you don't join the consortium and maintain your very high rate, we think patients won't go to your facilities anymore. So yun yung hatak doon. That if there's enough private facilities, we can bring down the price efficiently. And if that business model works for Gene Expert, maybe we can do that for quantiferon too, because it's a very expensive test right now.
Can I ask Dr. Celine about the striders? So is there an app that we could access those striders? I have a specimen. How do we access the striders?
As I have mentioned, Doc, you have to coordinate with the LGUs. We don't have an app for that.
Yeah. So I think you, diba, Dr. Celine, you coordinate with your LGU. So for example, Medical City coordinates with the city of Pasig.
Yeah.
Something like that. So Makati Med will coordinate with the
Pero if
Sputum
existing existing na PPM clinic, then they know that they have to go there.
So those are very hopeful game changers that will hopefully happen very soon. Okay, yes, Doctora.
Also for Dr. Garfin po. Doktora, also for extrapulmonary tuberculosis, the surgeons submit specimen for gene expert from the provinces. For our surgeon friends, what can we suggest as the proper storage of the specimen, given that some facilities only send all the specimens only once a week? Yung from Baguio po kami, tapos parang it's only on Thursdays that they submit all the specimens that were submitted. However, the surgeons are not knowledgeable of the proper storage, proper amount of specimen to be submitted.
Pero it's in Baguio only? Tapos,
From Baguio po kasi
Oo.
I'm not sure about the other provinces, but we have gene expert for sputum, but the gene expert for specimens are being sent to Manila according to our institution po.
Same lang, it should be in the sputum cup. Then they have to bring it to the or they should diba may striders? Wala kayong striders?
Sa Manila po lahat dinadala, Doktor.
Pero yung nagpapadala, isn't it, if they have to bring it, they don't bring it to Manila, but they have to bring it to the facility. Tama? Kasi dapat doon siya sa facility eh. Then the facility will transport the specimen.
Yung pag-transport, sila po yung gumagawa.
Oo. So they're trained. I'm not sure how it is done,
So
but
we can
they're
just-
trained how they have to transport. I know it's a triple packing, tapos merong ice doon.
Ice.
And they're trained.
Ilalagay po ba sa water?
Sa water?
Parang, di ba,
Dapat,
specimen
siya?
or tas ilalagay
Sa sputum cup?
Ay, sorry po.
Doctora, you're from a private hospital. You want to send to Manila.
General po. I'm from a government hospital.
Okay.
Pero these are specimen na tissue, mga tissue, extrapulmonary po.
Doctora can answer. Yes, Doctora.
Okay. For DNA, because with Gene Expert, it's a PCR method, you cannot put it in formalin. If you're going to request for Gene Expert, it has to be placed, if it is a tissue, you suspend it in either sterile water or sterile saline and put it in a sterile container. And if you cannot transport it immediately, you can put it in the fridge while waiting for transport and transport it in ice. I just don't know who will bring it to the laboratory. Maybe you can request is there any
Hospital
courier?
Na siya eh. Nasa hospital na siya, Doc, di ba?
Yes, but who is assigned in bringing the specimen to the reference lab who will do the Gene Expert? I think there should be,
Yung process is they bring it to the expert center.
Yes.
Then that if they are not able or they don't have the
They sh-
capacity to examine yung
Yes, sir.
extrapulmonary, then they have to send it to NTRL.
yeah, so you should have a messenger. Just request your hospital for a messenger.
May arrangement na yan siya, Doc. It's not the Strider.
Right.
It's not the Strider. We can discuss after.
Yes.
Bagyo Jen ka.
Are all specimens fit for Gene Expert TB? Because in NKTI, we have Gene Expert TB and TB PCR. And when we request for Gene Expert TB for the urine, for suspected genitourinary TB, they say you can't. It's not for the urine. But we've had experience that they accept TB PCR, and there are a lot of TB PCR positives.
So they don't accept for Gene Expert.
They say
Yung
it's not
urine.
indicated. So I'm not sure which specimens we can submit or not.
Based dun sa...
Buti na lang nandito si Dr. Lagamayo.
Actually, the Gene Expert is validated for sputum, bronchoalveolar lavage, and the CSF only. But in our laboratory, we can do the test, still do the test using our own protocol, and then put a remarks that this test was only validated for sputum, CSF, and bronchoalveolar lavage. But we can do such a procedure. We macerate it aseptically, and we suspend it in normal saline or water, and then we treat it as sputum. But then, but we get positive results with tissues and abscesses. We get positive result.
So fluids that are normally sterile.
Urine, yes. We just concentrate it, centrifuge, and use the sediment to run the test.
Okay.
But we have a disclaimer as a remark.
So can you just use the microphone?
In connection to the question of Dr. Ekarma, because we are always asked about like the PCR, both are PCR tests, right? But the other one is Gene Expert, and then the other one, I don't know, but they just said TB PCR. So in connection to Dr. Ekarma, is there a difference on what you want to send? Because Gene Expert would be a better test if it's the same, comparable, because you have the rifampicin resistance gene checked.
What you're mentioning about the TB PCR, that's another brand. Using another brand or an in-house PCR, another brand. So it's, I think, by Roche, if I'm not mistaken. Because with Gene Expert, we can detect both the TB DNA plus rifampicin resistance. With the just plain TB PCR, you just detect positive or negative for the TB DNA.
Right.
Though
So-
I don't think there is a difference in the. Yes, we can still do it. With blood, we also do blood PCR for TB using a protocol, Kiagen, for extracting the DNA from blood. There is a protocol, a kit for that particular matter. So we can do TB detection using PCR, Gene Expert. But first, we have to extract the gene, the DNA from blood specimen using the Kiagen kit.
Right. So for in-house, many experts would say maybe we should discourage quote-unquote in-house PCRs because we're unable to have controls or specific controls, unlike Gene Expert, which is already a standardized and an endorsed procedure. So kung you're going to invest, maybe you should invest on Gene Expert.
Doc, i-clarify ko lang na sa expert centers ng DOH, maybe except for NTRL because they have more equipment, we don't accept yung blood at saka yung urine.
Okay. All right. So I think we had enough time for questions, and it's time to give our certificates of appreciation to our very distinguished speakers. I'd like to call my co-chair to award the certificates of appreciation to Dr. Ana Marie Selina Garfin, to Dr. Marcela Gler, and to Dr. Masay Kawamura. So thank you very much, everybody, for staying on. Please stay for the closing ceremonies. Okay, for the closing ceremonies, we're all invited to go to function room 1. That will be where the closing ceremonies will be held. Thank you very much.